Very glad to be here. First, thanks to Alan and his team, Sagita, all the neurosurgeons. Thanks to all of you who see my patients and send me patients. Everyone tries really hard, so when we make errors, it's okay. We're all really trying hard. And I think the medical malpractice attorneys pointing out the facts that mostly the evidence is on our side. So don't be scared to practice medicine. Do the right thing. You're usually right. Yes? Your mic's upside down. It's upside down. Thank you. So that's one point. Secondly, I hope everyone did well with Halloween. Had a big take, because usually we buy too much. And fortunately, we only had like 20 kids, so lots of candy. And the most interesting story was the kid who came in with Spider-Man outfit and pointed out that his friend, who I looked at, was in a mask. I said, "What is he?" And he told me he's a murderer. And so I gave him a huge bag of candy and closed the door. And that was the end of my night. I have not heard of going as a murderer, as a child, to trick or treat. It was quite impressive. There was no parental supervision, by the way. So we're going to talk about things that happen that we don't want to have happen, which is make an error. And everyone has done that, who's practiced any amount of time. And whether you're a physician or not, we all are making assessments and judgments, and we can make some errors. My goal is to help you understand some specific conditions directed toward what anybody can encounter, but keeping in mind where the overlap in neurology and neurosurgery are quite common, what might you see or fail to recognize? And many of these things I've encountered myself. I've either been the person who was involved in the error, correcting the error, or sharing in the guilt of, well, we missed it, but then we eventually got it right. It just happens frequently because there's a lot of overlap. And if you've operated on someone's spine before and found, as so many people have, that there are multiple comorbidities, it's tricky to tell, well, is that the spine or is that not the spine? And how do we know? And I'm going to talk to you about how we figure some of these things out. The other clicker. Psych. The general categories that we encounter are going to be simplified as brain, spinal cord, peripheral nerve, and the neuromuscular junctions. Just in general, a lot can happen from a brain disorder, and everyone knows that. Anything from an altered mental state with the confusion, you can have a headache, and numbness, weakness, dizziness, language disturbances, memory loss. So as a general concept, I'm going to talk about a 60-year-old presenting with progressive numbness and weakness one side of the body over the course of 3 months. Well, that could be a lot of different things. But let's say imaging suggests maybe this person has the worst case scenario, the dreaded diagnosis of a glioblastoma multiforme. It's terrible to see when you look at it in radiology. It's terrible to have to share the news, and it creates the expected reaction of how much longer do I have to live, and how are we going to know? Very commonly, we'll have all of us look at a film, from the surgeons to the radiologists, the neurologists, and say, yes, it looks as if that's what's going on. Talk to the family. Obviously, all the questions come. You can only dampen down that fear so much before the person goes to surgery, hoping the neurosurgeon will be able to get it all out and lead to a good outcome. But what if this pathology comes back after you've laid the groundwork for what might be going on and it's not a glioblastoma? It's happened probably, for me, 4 times in 25 years. First case was in residency. Someone presented a case because they showed the images and everyone was like, ah, yes, GBM. And the pathologist then tells us, no, it's demyelination. And we've had a case here that I've shared with the neurosurgeons who's an active patient of mine still, that over 10 years ago, we thought it was a glioblastoma. It was multiple sclerosis. And he, as a very lovely man and attorney, said, hey, you guys did your best. I'm so glad it's MS, not a brain tumor. So it does happen. And when we saw that, we're happy, but it's still a scary moment when you're admitting that you didn't know. And when you see that, you're able to say, we can treat you like multiple sclerosis, and the prognosis is rather dramatically changed. We treat this condition with the same medicines you do any form of multiple sclerosis. It isn't always a large mass lesion. That's the one that most commonly looks like glioblastoma, but it can be multifocal. And just by some interesting coincidence, a patient I have in the hospital right now who's 24 came in with multifocal cavitary lesions, gadolinium enhancing, and we don't, in this case, do a biopsy on him. We're doing spinal fluid analysis, but it almost certainly is multiple sclerosis. And radiology put in their differential tumefactive MS versus metastatic cancer. But he doesn't have the presentation of someone with metastatic cancer. He's otherwise quite healthy until just a week ago when he started having funny eye movements and a droop to the right side of his face. So you'll see it very rarely, but it's fascinating when we do see it. Now, when it comes to spinal cord pathology, it's one of the trickier areas, and you wind up with this mix of symptoms. There can be pain, numbness, weakness, bowel and bladder complaints, or poor balance. And then there's the asymptomatic pathology. Occasionally someone gets a film for some other reason. Radiology says, oh, by the way, we see that the spinal cord looks as if it's compressed. And you wonder, what does that mean and what do we have to do about it? And we won't give the lecture today on the history, the natural history of spinal stenosis. That's been done at this conference many times. But it does come up. And sometimes the question is from Alan or his team, what does this Alan think in terms of whether it's a good idea to maybe move forward or not? It's not easy to answer because there isn't the right or wrong answer. There's just trying to present the data that you're at risk of a serious problem if we don't decompress, but who says you're going to have a compression? So not dissimilar to Lee's argument about should you start smoking pot to prevent something from happening? Should you always have an operation to prevent the fact that you might have a car accident? Not right or wrong answer, just options. So let's talk about a case in which patient has upper extremity atrophy. That means wasting away of muscle in some distribution. It's quite common. A lot of people are asymptomatically presenting with atrophy. Very commonly, it'll be in the ulnar distribution. They won't even know. A little bit of weakness, no significant pain. Part of the theme of this talk is that pain matters for your differential diagnosis quite a bit. And symmetry matters as well. Asymmetry should start getting your radar up on something's a little atypical about this. Reflexes being increased and decreased, that's atypical. Usually it's nice and symmetric, left and right, top and bottom. As soon as you see the differences, then you have to start questioning, why is that happening? If you see that pattern, one of the main differentials is that myeloradiculopathy of some sort. Something affecting the spinal cord, something affecting the nerve roots, and compression should be on the list because of the urgency if it's a severe compression, or something intrinsically within the spinal cord, such as a lesion of multiple sclerosis or something else. This case will all come together as I present what we found on a particular case, but if an individual has fluid-filled cavity called a syrinx, they can have sensory complaints, motor complaints, asymmetric reflexes, increased or decreased reflexes depending on the size of that fluid-filled cavity. And if that is large enough to compress sensory fibers, you'll wind up with this peculiar complaint of a suspended sensory level. It's like wearing something around your body where you say, well, it's numb here, but it's fine below and it's fine above. That has to do with the anatomy of how those spinal thalamic fibers cross in the central canal region of the spinal cord. And if you're impinging on that, people describe this funny bra-like sensation or something wrapped around their body, a hoop around their body, those kind of descriptions. It's a red flag to think spinal cord. Doesn't mean it always is, but usually across the chest or abdomen, you're going to find something in the spinal cord. If we look at the spinal cord and we don't see anything specifically, then there's this differential question of something called ALS, where individuals don't usually have pain, they have a lot of weakness, but prominent asymmetric findings. One side is weaker than the other, reflexes are different. So we had a case like this, which Dr. Beasley was involved in with me. I sent her for a second opinion on a person who came, looked at his case. He was coming in because he was having weakness. And sadly, a lot of people present to the neurologist with weakness and have ALS but don't know. They had no idea. It wasn't even crossing their mind. But if you've ever seen someone for the first time and seen the prominent fasciculations, it's a pretty sad moment because you realize what's probably going on just from looking at that alone. Not always. So we did the imaging, and he had a small syrinx, a little bit of fluid inside the spinal canal, cervical level. And we talked about that, and he read about that, and said, that's probably my problem, right? And I said, well, probably not. It's a small syrinx. So we spent a lot of time talking about that, and I spent a lot of time helping him get more opinions, because he wasn't ready yet, as most of us are, to say, well, that can't be true. How could I possibly have that? I'm a healthy, thriving 50-something-year-old. Ultimately, though, he did have that as the diagnosis. And he went from me to Dr. Beasley to the University of Colorado and is getting the treatment he needs now. So those asymmetric presentations are what throw us off, and you sometimes see spinal cord pathology, whether it's compressive lesions or something within the cord. And very often people have even had cervical decompressions appropriately for a foraminal stenosis or a cord stenosis, where later, 6 months down the road, they aren't really getting better. In fact, they're getting worse. And the follow-up imaging shows absolute perfect technical skill on the decompression, yet this person's got a progressive weakness syndrome, which only in retrospect you say, well, it turns out probably asymptomatic lesions, but an underlying neurodegenerative disease. So what is ALS? Most people have heard of it. Most of you have encountered patients with it. It is a disease of the motor neurons, and it's the motor neurons up in the brain and down in the spinal cord. Those anterior horn cells send the processes down to your muscle. There's not a sensory component, so pain isn't common, and no pain with progressive asymmetric weakness makes you suspicious for that particular disease. You can have cranial nerve dysfunction, and for those individuals who have trouble chewing and swallowing, the prognosis is worse because it's an early problem that puts them at risk of aspiration and respiratory failure. But the hallmark of the disease is the asymmetry, arms and or legs. Fasciculations are almost always present early on. Most of the time people will be aware of it. Often they don't recognize the extent of it until you really look at their body and see it. Or they just didn't think it was particularly unusual. Many of these people are very athletic. For me, the reflexes are the go-to to help figure out, well, is it probably that syndrome, because you'll see the mix. Corticospinal tract is affected. That leads to increased reflexes below that level. And anything from the anterior horn cell out leads to the loss of reflexes. And when you see that mixed pattern, even in one limb, you'll see a mixed pattern sometimes. You should be thinking about that condition. The sensory complaints are rare. When they do come up, it sometimes is part of a presentation for a frozen shoulder syndrome. I've had a PT more than once send me a patient saying, yeah, they came to me for frozen shoulder, but there's something really wrong with this person's arm, and it's not a frozen shoulder. Yes, it's that, but there's something wrong, and the atrophy. And most of the time they're thinking ALS, but they don't tell the patient that for good reason at the beginning. You diagnose it clinically, but then you use the EMG to rule out other conditions and try to find that specificity. It's an alarmingly abnormal EEG when you see it. You'll see classic changes of active denervation, fibrillation potentials, fasciculation potentials, and mixed patterns of chronic and active denervation. It's still incurable. It's still fatal for the vast majority of people. Survival is highly dependent upon age and comorbidities, as well as what part of the nervous system is affected early. If it's affecting chewing, swallowing in this zone, the prognosis is shorter than that. And then affecting a single limb, the person may live well past 2.5 years. We have very limited treatments. There are a lot of supportive treatments. You do a lot of things for respiratory support when people are starting to drop their vital capacities. And you can do some medications. 2 currently FDA-approved treatment. One came out in the US just 2 years ago. The other one, Riluzole, has been around for about 20 years. They do have a significant prolongation of survival and delayed time to going on a ventilator. And people have mixed opinions about whether they want to take them, but it's pretty universally accepted that we would at least offer it to patients to say, what are your choices for a condition for which you will probably succumb eventually? But we have had many people live many years, and no one more famous than Stephen Hawking. Moving away to the peripheral nervous system, out of the spinal cord, it's probably the most common thing we see is something is tingly and something hurts, and we're looking for something like carpal tunnel, or we're looking for an ulnar nerve problem, or just the generalized, my feet are tingly and numb. We see it all the time. Usually it's distal feet, tingling, numb, a little bit of weakness, and some degree of sensory change. That part's relatively straightforward, but what if it seems a little bit atypical? So a 32-year-old man having spontaneous left foot drop, prior history of bilateral ulnar nerve decompressions, carpal tunnel release surgery. Is that particularly common at 32? Probably not. Now, he might be a factory line worker or he might be a mechanic, and sure, there's a lot of wear and tear on their joints and hands and activities where you might say, well, yeah, that seems reasonable, but it isn't particularly common. And the treatments, they worked a little bit. If he has that foot drop, is it time to ask someone to go work around the fibular head, explore that, and decompress the area? Well, why could this be something else? One, it's a little bit atypical. It's a lot of nerve problems for an individual. Let's say he doesn't have any particular known risk factors. What if we said mother and sister had kind of similar story? And we do an EMG and we see multiple areas of slowing across certain segments. Motor and sensory fibers affected, distal sensory changes might be present. If it's autosomal dominant, mom affected, sister affected, then we have to think about this interesting thing called HNPP. That's the hereditary neuropathy with liability to pressure palsies. Fascinating genetics. It was known genetically over 20 years ago, but it's one of the tests you can just send to the lab and you can get the answer. We don't usually do that. Sometimes we do it. Most of the time it's a clinical diagnosis. My guess is we underdiagnose it because a lot of people have carpal tunnel and ulnar neuropathies, and foot drops aren't that rare. But keep it in mind if someone has recurrent issues as something to inquire about and say, I wonder if there's a genetic predisposition, particularly when there isn't a clear-cut story of, well, why did you get that? It is autosomal dominant. It's caused by a particular mutation in this PMP protein, that's peripheral myelin protein 22. And it has an allelic variation, which is better known to most people as Charcot-Marie tooth. So if you have a duplication rather than a deletion of this same gene, you'll wind up with the phenotype of Charcot-Marie tooth. So that's the high arched feet and the inverted champagne bottle legs. So you'll wind up looking at these individuals, and anybody who's done any form of therapy with patients has seen that individual where you quickly look at the feet with hammer toes, high arches, and near foot drops and think, probably a genetic disorder, probably Charcot-Marie tooth. We can't treat it with anything specific, but it's nice to get the diagnosis for genetic counseling purposes, help people understand the natural history, and that's usually what comes out of it. All right, within the more distant category of the neuromuscular junction, one of my favorite areas, we studied it a lot when I was in Atlanta. But the neuromuscular junction is the connection between the motor nerves and the muscle. That's how we take an electrical signal from the nerve and get it to a chemical signal, back to the muscle, to an electrical signal to make a muscle contract. Acetylcholine is the key molecule involved here. It's released on the presynaptic terminal and goes and binds to the postsynaptic terminal, and then you wind up with a muscular contraction. What happens when acetylcholine is released is it gets broken down very quickly by an enzyme called acetylcholinesterase. So here's a case presentation where a patient is weaker than expected after routine anterior cervical fusion. Weaning from the ventilator seemed challenging. Then we see a little bit of drooping eyelids, disconjugate gaze, but somewhat variable. One staff member might see it, the other one might say it's not there, and that leads to confusion. Well, what's happening with this person? Usually the weakness, proximal, not a lot of distal weakness, no seeming sensory deficits. Once the person's extubated, the spouse said this person's speech is slurred at times and swallowing has been a bit difficult. So what is likely going on? Well, in a case like this, what's likely going on is something at the neuromuscular junction. Not definitively, there are differential considerations, but that's a lot of the key features of myasthenia gravis. You don't want to miss myasthenia gravis because it's so treatable. And it often presents for the first time under a physical stressor of having surgery, or in individuals in the ICU having been through sepsis, and they were on the ventilator, but something's funny about the weaning that doesn't make sense. Everything should have been straightforward, but it isn't. And generally older individuals, you can see it in young people, but it's quite rare in the young. There are genetic forms that happen even in infants, but we don't ever see that. We don't take care of people under 18, but it exists. But the form to know about is the older, past age 50 typically, presenting with all of those symptoms. And it does fluctuate. There are ups and downs, and it gets worse with repetitive use. And there are physiologic reasons for that. If you're repetitively using your muscles, you can deplete the degree of acetylcholine only so much before you start to get weak. No sensory involvement, though. That's what separates it from a lot of the pinched nerve conditions, the brain conditions, and a lot of the spinal cord disorders. Anytime someone is weak with no sensory complaints, particularly with those ocular and bulbar symptoms, a droopy eye is one of the most common things, and it's something funny about their eye movements. You can have considerations of ALS, because you don't always have bulbar involvement with myasthenia gravis, and Guillain-Barré syndrome are considerations, but ALS isn't a sudden onset disease. Guillain-Barré is, relatively, so people can present with the Guillain-Barré syndrome, an autoimmune attack on the peripheral nerves, and they can have ocular, bulbar findings, peripheral nerve findings, but usually they don't. So we wind up doing lab tests, specifically looking for antibodies in myasthenia gravis against the acetylcholine receptor. If someone has systemic, widespread condition, it's about 85% chance the antibodies will be positive. If they have just ocular finding, it's about a 50% chance. So you're stuck sometimes using your best judgment and then empirically treating with therapies that can lead to improvement in that acetylcholine. There's a very interesting characteristic pattern you can see on EMG. If you give a repetitive shock at 3 cycles per second, there's a decrease in the compound muscle action potential characteristic of that disease. And then about 15% of the time, there's an associated benign tumor of the thymus gland. If people are under age 60, you take it out and it can help people improve them. Over 60, most of the data says they don't need the surgery. Usually a good prognosis. The gravis part was in the era when we didn't have good ventilator care. And for my senior colleagues when I was in training, they talked about those eras of, they manned the iron lung. There was the polio era, and there's myasthenia gravis, and someone had to be with the patient all the time, helping them through this terrible condition. They didn't have much great treatment, but we have now really good treatments, and usually you put this into remission effectively with a quick treatment of plasmapheresis or intravenous immunoglobulin, and those are highly effective in the ICU or acute settings. In that time, you can wind up implementing immune-mediated therapies, prednisone and or Imuran and or a series of other immunosuppressant options. Pyridostigmine is sometimes overstated as how beneficial it is. It is used to block the breakdown of acetylcholine, and you say, great, just push up the acetylcholine. Turns out it helps mild disease, but it doesn't help aggressive severe disease. It's usually ineffective at that. But once someone's in remission, people who are getting ready to give a talk or participate in an activity where they're going to be speaking or chewing, going out to dinner, they might take a dose of this just to keep their acetylcholine levels up, have a better experience than they would otherwise. Okay, so my key points are that when something seems unusual, trust your instincts, say this seems odd, and dig into it. If you're not sure, seek out the consults that we all need to. In a general sense, dividing issues into could this be brain, could it be spinal cord, maybe it's the peripheral nerve, maybe it's the neuromuscular junction, is a good exercise to run yourself through all the possibilities, thinking about, okay, well, are there sensory complaints or not sensory complaints? And do I see changes in the reflexes that can guide me? And if you aren't sure, again, we like to see interesting cases. Endless cases have come from the neurosurgeons where I say, I don't know either, but I get at least a chance to say, maybe I'll figure it out and be the hero or not.